Thanks for joining. My name is Daniel Gober. This video is going to be a little different than previous videos in that I'm not going to be talking about any biomaterials per se. Rather, I want to talk to you about the autogenous free gingival graft around dental implants. The question of whether keratinized tissue is necessary for peri-implant tissue health has been the subject of debate for as long as I can remember. I think we've all seen implants with a lot of keratinized tissue that have inflammation. We've seen implants with no keratinized tissue that appear healthy. But it's important to realize there was a systematic review in 2021 that concluded that keratinized tissue was a good predictor of peri-implant tissue health. And so I think that it's prudent upon us to make sure that whenever we're placing implants that we provide a peri-implant tissue complex that's healthy with good keratinized tissue to improve the long-term stability of the implant. The gold standard for increasing the width of keratinized tissue is the autogenous free gingival graft. This works, and it works really well. The major drawback of this procedure is that it's typically taken from the palate, it's an open wound, and post-operatively it hurts, and it could hurt really bad. What I found is that fabricating a palatal stent with coverage over the wound is very helpful for the patient during the first week, so I would encourage you to fabricate that for your patients if you're going to go ahead and perform this procedure. So is there anything we can turn to avoid going to the palate or to the patient's own tissue? And unfortunately, the answer to that question is no. The reason being that in order to change the keratinization of the epithelial cells, the genotype of the connective tissue has to change. And these substitutes do not do that. They are helpful when it comes to vestibular extensions. And we've spoken about them in terms of thickening tissue when you're keeping them under a flap. But in terms of increasing the width of keratinized tissue, these are not going to be helpful. So we're going to have to turn to the free gingival graft to get done what we intend. Let's get to our first case. This was an interesting case to me because the surgeon was a very competent surgeon. He placed an implant, restored it with a cantilever. All signs pointed towards integration. But the patient was still complaining of this persistent discomfort, very hard for her to identify. He referred the patient to me just to get another set of eyes. And the first thing that I noticed when I looked was that the tissue quality in front of the implants was frankly very poor. You could even see that the margin was pulling away as we pulled the lip to take a look. Tissue is very thin, no keratinized tissue, almost no vestibular depth in that area. You can see the plaque accumulation. So I told the patient that I recommend a free gingival graft to correct this and hopefully be able to get rid of her symptoms. The first thing you want to do is a recipient bed prep. The idea here is that you want to excise the surface layer of the mucosa and leave some periosteum that you can bind the graft to. I typically will use sutures to tack down the vestibular extension just so that it doesn't tend to creep up during the initial healing and cover the graft, although I don't know that that's absolutely necessary. When you're looking at the bed prep, you just want to make sure that the periosteum is firm. There's not a lot of tissue tags. There's not a lot of areas of mobility. And then you can go ahead and harvest your graft. Here's a picture of the tissue graft. It's important to realize that these grafts really go through a lot of shrinkage. There's primary shrinkage, which is when you take it right off the palate and the whole thing starts to contract. And then there's secondary shrinkage that occurs when the graft is healing. So, we used to have a joke in residency that whatever you think you're going to need, take double. So you got to make sure that if you're going to harvest and you're putting the patient through this anyway, make it count. Once you place the graft on the recipient bed, you just need to ensure that you have total graft stability, no mobility at all. What I typically do is I'll place a few interrupted sutures at the coronal aspect, and then I'm going to use a continuous mattress suture over the graft as much as I need to in order to ensure good stability, because if the graft is mobile and it moves during the initial healing, then it will fail. Here we are about 6 weeks later, and we could see that we've had successful take of the graft. Despite that, you can appreciate how much the graft did shrink relative to the initial placement. Nevertheless, this procedure was successful. The patient's symptoms did go away, so that was the best part. Unfortunately, I wasn't able to continue to see this patient after this, but I'm confident that this graft just continued to mature over time and look better and better, because these grafts tend to do that. For our second case, I just want to show you, this was mandibular arch. 2 implants were placed to facilitate an overdenture, and it was time for uncovery. And if you take a close look and you outline where the mucogingival junctions are, you can see that the width of keratinized tissue in the areas of the lateral canines where the implants are is very, very thin. So if you were to just split this in half and push a little lingual and a little facial, you probably would end up with nothing. And so the plan here was to take whatever keratinized tissue is present, push it lingual, and do a free gingival graft on the facial of the implants at the time of uncovery. Made a full thickness incision at the level of the mucogingival junction, pushed the keratinized tissue lingually, exposed the implant, and placed healing abutments, and then just went ahead and prepared recipient beds on the facial for the graft. Employ the same method in terms of adapting the grafts to the facial of the implants, mattressing over them with some gut sutures. 8 weeks later, and we can see that we had successful take of the grafts. Bottom picture shows you that we have keratinized tissue 360 degrees around. And I think that had we initially just split whatever keratinized tissue was there and not done the free gingival graft, I think we would have ended up with no keratinized tissue at all. Thanks so much for your attention to the video. If you have any questions or comments, feel free to click on the link below. Otherwise, I'll see you next time.